Let me introduce you to Cristina Lumia, which is a midwife and a PhD candidate. Courage to complete it, Cristina. A PhD candidate in nursing and midwifery at the University of Milano Bicocca, Italy. And she has a solid clinical experience gained across different Italian hospital settings. Her research and knowledge translation activities address sexual and reproductive health, cancer prevention, and perinatal mental health. Her professional interests focus on strengthening the integration between clinical practice, research, and education in order to improve women's health outcomes. So welcome, and I'm pleased to listen to what you want to share with us. So I will stop the sharing, and you upload your own presentation.
Okay, perfect. Okay, thinking you can see the presentation now.
Yeah,
okay.
No problem.
So, hi everyone. Thank you, Celine, for the presentation. I'm from Italy, and today I would like to share with you the finding of a scoping review on midwifery practice in perinatal palliative care, and to present to you a conceptual framework that we developed based on our research. So let me start with a simple question to all of you. Why does this topic matter? We know that perinatal palliative care is an area that is growing globally. More and more families are facing pregnancies complicated by life-timing fetal conditions or uncertain neonatal prognosis. The situation required extremely complex and emotionally intense decision-making processes. In this context, midwives are always present. We accompany women and families across pregnancy, birth, and postnatal period, of course. And yet, despite the central presence in care, our role within the perinatal palliative care remains unclear. This leads to what I consider the key message of our study. Midwives are everywhere in care, but nowhere in literature. We already know that perinatal palliative care is an holistic, family-centered care focused on the quality of life instead than only cure. And importantly, it is based on a multidisciplinary approach. So the philosophical and organizational foundation of perinatal palliative care are already well established. But when we look more closely to the literature, a clear gap emerges. Most studies are focused on parents' experiences, and this is very important because we can manage our assistance, our care about the expectation of parents. And our other studies are focused on physicians' perspective and experiences, but midwives are often grouped with nurses only or described very generically within the sentence healthcare professionals. This creates an issue. There is a lack of clarity about what midwives actually do in perinatal palliative care. For this reason, we designed the study with three main objectives. The first was to map the evidence available on midwives in perinatal palliative care, to identify the real gaps in literature, and to explore how midwifery practice is integrated in care pathways. So we conducted a scoping review following the Joanna Briggs Institute methodology and the PRISMA scoping review guidelines. We searched in the measure databases included PubMed, CINAHL, PsycInfo, and Lemay, and the search was conducted between May and September 2025, and we decided to include only the primary studies. This is the PRISMA flow chart of the study selection. We initially identified 79 records. We screened 57 for title and abstract, and then we read through 23 full text, and we included 11 studies at the end of the scoping review. These are the mainly characteristics of the studies that we included. The first was that we found only studies from high-income countries published after 2010, because we supposed to have a more interest after this period, and in particular in the recent period, and they mainly focus on professional experiences of the healthcare in general, and they were focused on clinical and organizational frameworks, and in particular guidelines. These are the results about our analysis. We conducted a thematic analysis according to Brown and Clark, and two domains emerged. The first was the professional experiences and preparedness, and the second was organizational and clinical framework. Domain one is quite important. The literature outlines that healthcare providers involved in perinatal palliative care sometimes experience a significant emotional burden, a moral distress, and a lack of specific training. This is a very important point in my opinion, because we provide PPC, the perinatal palliative care, in a context that is not only clinical, but also very emotionally demanding. If we think about the parents, or if we think about the providers too. So professionals often face a ethically challenging situation and may feel unprepared to manage them. At the same time, literature shows that some factor can significantly improve the professional experience of those involved in PPC. The first, we consider the mentorship. The mentorship play a crucial role. Having the opportunity to work alongside more experienced colleagues allows professionals to develop not only clinical skills, but also ways of navigating emotionally complex situations. So the mentorship provides a safe place to reflect, to ask questions, and to process difficult experiences, which is essential in midwifery field in general, but in this field of palliative care, I think is quite important. The second was the clinical exposure. Professionals who have more experience with PPC situation tend to report higher level of confidence and comfort, like in other activities that we are involved in as midwives. Exposure helps transform uncertainty into familiarity and allow the clinicians, midwives, and all the providers to gradually build both competence and emotional readiness. The third is the supportive organizational system, which is very fundamental. This includes the presence of a clear care pathways, institutional protocol, interdisciplinary collaboration, and the spaces for debriefing and supporting the emotion. When professionals feel the support of their organization, they are better able to provide consistent and compassionate care. Together, these elements are crucial because they do not only improve technical competencies, but also strengthened the confidence, the emotional comfort, and the resilience of the system and of the professionals. And this is particularly important in the PPC, where professionals are constantly balancing clinical responsibility with deep emotional involvement. The second domain is the organizational and clinical frameworks. They are actually well developed in literature, but there are a clear model of care exists. But I want you to remember that we are talking only about the high-income countries. So we need to focus in the future to the low middle-income countries, for example. But the clear model exists. They are strongly in focus and emphasizing the quality of life, the family-centered care, and the shared decision-making between families and between professionals. However, despite these well-defined frameworks, midwives are rarely explicitly described, often merged with other professionals, and not clearly positioned within the care pathways. So this leads to a paradox, in our opinion, because midwives are not explicitly recognized in PPC, but midwifery values are perfectly aligned with the principle of palliative care. For example, if you think about the continuity of care, the relational care, the effective communication, and the family-centered care. These are the values and the principles of our professionals. So these are core elements of midwifery, of midwives, and at the same time, fundamental principles of PPC. To try to address this gap, we developed a conceptual framework grounded in the evidence identified through our scoping review, but also informed by midwifery theory and practice. At the center of this framework, you can see that we intentionally place the woman and the family. This reflects a fundamental principle that perinatal palliative care is not organized about the condition, about the diagnosis, the illness, but around the lived experience of the entire family. Around the central core, we structure the continuum of care across the mainly phases of the midwifery practice. So the antenatal, the intrapartum, and the postpartum period, with the bereavement care. But this is very important because we don't consider only a single moment, but a longitudinal process that unfolds over time, often across different settings and professionals. Within this continuum, the midwife is positioned as a connector across all the phases of care. And this is really the key idea of this framework. Midwives are one of the few professionals who can accompany, maybe the only we can see together that accompany women and family continuously over the entire life, over the time, moving across clinical setting while maintaining our relationship, our relational power with the family and with the woman too. If you think about the box number 2, promotion of sexual and reproductive health. This is important when we consider a woman who experienced before a palliative care for the newborn, but in the future, maybe she could think about another pregnancy, and we have to support this woman. So we want to maintain communication between the professional, between midwives, support the woman who wants to share their decisions, and try to maintain the coherence into all the pathway, all the care experience. So this framework does not introduce a new role for midwives, in my opinion, but rather makes visible a role, a practice, a competence that is already being enacted in practice, often implicitly and without a formal recognition. So ultimately, it highlights how midwifery is not peripheral, but central to delivery of truly integrated, family-centered palliative care. These are the main implications. If we think about the practice, we hope for a clear recognition of midwives that provide perinatal palliative care, because we do this every day, but without formal recognition. We can consider implication for education. So maybe we can integrate also this field in the undergraduate or maybe postgraduate curricula. And for research, of course, we need to focus on studies that are specifically focused on midwifery, on midwives, and the contribution, and competencies and the practice of midwives involved in PPC. And as said before, also for the context of the research, because we are talking about only the high-income countries. So these are the take-home message that I want to share with you. And maybe we can discuss together about them, sorry. So PPC is expanding all over the world. There is a clear recognition of the palliative care in general as a primary care priority. So we have to be involved in PPC very clearly, because we are central, but we don't have to be under-recognized in the future. So we need to make the role visible, structured, supported, because I truly believe that midwives all over the world are already doing this work every day. The challenge now is not to invent a new role, but to recognize, to name, to support what is already happening in practice. So if you are interested in the full article, you can read it in Woman and Birth in the last issue. And if you have questions, we can talk together now, or maybe this is my personal email if you want to exchange some opinions or discussion. And thank you so much for your attention.
Cristina, thank you so much. It's an important message to take home and to be conscious about the importance of the presence of the midwife, the consciousness in the moment and the palliative care with the children and babies. Is there any question or commentary? I wrote things, but yeah, it's time to ask question. Let me see if you can unmute yourself. Can you? Let me see. Oh boy.
Oh, okay, this is a real program. Yeah.
Hello.
Hi.
Hello.
Hi. Hello. Thank you for the presentation. I wanted to ask if perinatal palliative care is actually well established in Italy, because it's not like a widely recognized and widely established concept all over the world. I mean, I know there are pockets of good practice, but there often aren't like specific teams or named professionals who lead on that care. So I think that's part of why midwives are not recognized for it either, because it's generally a concept that's not so well known.
Oh, yeah, I agree with you. Sometimes the teams are very different in professionals, and in some parts of the world, midwives are included. In Italy, we have differences in the regions. For example, if we think about the north, we have one hospital with a specific protocol in which midwives are involved. For example, when the woman decides to to donate the milk, for example, or because sometimes the palliative care occur after a starting of the breastfeeding, for example. Or another situation is in the center of the Italy, in which midwives are starting to be involved, but is quite difficult because it's not highly recognized as a skill of the midwifery in particular, but also for nurses or pediatric nurses, because in Italy we have differences in professional. We have midwives, nurses, and pediatric nurses. So it's not easy to have a particular recognition of the role completely and universally in all all the nation. I don't know if I answered.
Thank you.
Thank you.
And I like, Cristina, that you insist that to distinct nursing from midwifery, because they are two unique and distinct professions, and you claim something clearer and to assume as a professional identity of unique about midwives and not mixed up with nurses.
Yeah, I know that this is not a situation of all the countries in the world, because, for example, maybe the colleagues from the US are better informed than me, but sometimes midwives and nurses are the same professionals. In Italy, we have a clear recognition of the roles, of the competencies, and the identity of the nurses and of the midwives are different but strongly independent. And we recognize the midwives as a key role for support the woman in the entire life, the woman and the family. This not means that nurses are outside the clinical pathways, of course, but maybe midwives is quite prepared from the curricula, from the university curricula, to be involved mainly in woman life and in woman health.
That's good to know. Is there another commentary? Yeah, I wonder I have a question for you. I wonder how can a teacher or information for student midwives, what would be a good thing to help a midwife to feel like confident to be in that part of, welcoming life when the baby is crying, but welcoming life when you know that the baby will go. Was there any special courses or, yeah, what is your experience?
There's no specific course, but the idea of this research came from one of my students. This is I support her bachelor thesis because she went to a conference in Italy in which the neonatal palliative care was introduced to the audience. And she comes in the university, said, okay, I just want to improve my knowledge because I think that is something very important for the future, and maybe the courses or the bachelor degree is not clearly focused in this field, but however, the students are curious. So maybe it will be an idea to improve this field also in the future. So we care about to publish this research to greeting for Sarah that had the mainly idea, but also for give an idea of over the world to the importance of the research in this field for the midwives all over the world.
Hmm. Well, yeah, thank you. Yeah. Was there any sharing discussion with people not specialized but experienced in palliative care for adults, but what it is about working in palliative moments? So for adults and for babies or whatever, it may be the attitude or virtues or ethics of that can be shared and be making clear, as well as, it can be for adults, but it can be for midwives.
Yeah, and I think that sometimes when the population and the society thinks about the midwives, only think about the the beautiful moments, the most important moments of happiness, and but sometimes we are clearly involved also in very sadly periods, sad moments. So for adults, maybe it's quite accepted, maybe. But for babies, it's something very hard to understand, to accept. But it's in this point that our communication, the importance of relationship that midwives has with the family, with the woman, with the entire community, that we can try to support this particular sadly moments. So it's very good to say that we are not here just when it's sunny outside, but also when the moment is quite hard. And that's why I'm very caring of this. I'm caring of this research because I want to share with other colleagues that we have to improve the communication, the decision making with women, with families, also when it's not sunny outside. So it's very important for us as a professional in the community.
Thank you. We certainly, midwives, need to cultivate humility of the possibility to control everything and to be responsible for life and, all things, but and help parents to live with that powerlessness.
Yeah.
And it's painful and it's sad and it's fear. We fear this and we don't want this. Nobody wants that. So wow. And yeah, maybe values of our society doesn't help us to be prepared for that. But so that's why prepared midwives would be so important.
Important. Yeah, of course. I think there is a question from Wilson. Do you think this concept can work in low middle income countries? Oh yeah, absolutely. If I can answer, Celine, I can say that the studies are probably from high income countries, because in my experiences, I think that in the high income countries, the conception of death is hard to accept than in the low middle income countries. That's why it's something culturally mediated, I think, because when a baby die in a high income countries, is something that you say no. Why? Because I have the possibility to do my best, but I think that in the low middle income countries, this is quite important too, because we have rates of deaths of women and baby too that are very, very, very high. But it doesn't mean that we don't have to be compassionate or prepared to understand also the suffer of a woman that culturally accepts the death better than another woman. So I think this concept may be culturally mediated, of course, also for the low middle income countries, and it will be an idea um, to have some research in this context and understand if women have the same experiences, the same feelings of the others. So thank you, Wilson, for the question, and I don't know if I answered. Well said, thank you.
And Catherine, do you have a question? No. Okay.
I just liked it. I appreciate it very much. I think it's such a gift that we can be there for families in this way.
I
well
agree.
said.
Thank you so
And
much,
if we're
Kristen.
ready, we can really transform someone's experience and then how they enter into their entire future relationship with their family, future children, and their ability to still live a meaningful and powerful life full of autonomy and potential power, joy, and find joy, like still put
Yeah.
it somewhere, but still maintain joy.
Yeah, I agree.
I like that you talk about joy and we can talk about love, you know, all in life of families. Thank you. Is there one more question or commentary? It was powerful. And it, yeah. Yeah, it puts us.
I agree that sometimes we are invisible in some situations. This morning I was talking about with a colleague for the cancer assistance to women, and she said, I think that women appreciate more the compassionate care of a midwife also during the chemotherapy, for example, because it's something very close to our identity to be in relationship. Is our power. I don't want to be mean with other professionals, but I understand that we have a very good power in many fields. So I think the palliative care is one, but maybe we can talk about the oncology. So I want to empower all the colleagues to not be invisible. Absolutely. We are visible. We are here.
We need to be more visible as midwife, and not just as what I say, good girls, conform to protocols and algorithm and guidelines and all that. But it's more than that. It's not just doing, it's being. So
it's not only practice.
Yeah.
It's not only doing things, but very be compassionate, be present. Sometimes with silence, but be present. Be here, be there for women and for families. I know that from the women that I met in my career, also to take an end was a power. So without any words or without discussing, but just to take the end. So we have to be conscious of our power.
Yeah. Thank you for talking about the presence. In Quebec, where I practice as midwife, we're talking about holding space, protecting. There's something precious, important, and deep that has to be, guardian in our consciousness about what's happening for
Yeah,
people.
absolutely.